All right, we're just after 2 o'clock, so we might kick off as we do have quite a full session this afternoon. So just check, can everyone hear and see my slides? Perfect. Great. Welcome everyone, and thank you so much for joining us this afternoon for the workshop Connecting Research Evidence to Policy Decisions. My name's Alex Hall, and I'll be one of the facilitators this afternoon. Just before we start, I would like to acknowledge and just say thank you to Seri for organising this workshop and today's symposium, as well as all the partner CREs and partner organisations. I would also like to acknowledge the traditional owners of the lands on which we're meeting on today. For me, that's the beautiful lands of the Awabakal people, and pay my respects to elders past, present and emerging. Now, we do have quite a full-on jam-packed session today. So we're starting with a bit of background and a bit of theory about what evidence is and the role of evidence in making policy and practice decisions. We'll then break off into a small interactive activity, which will get us talking about and thinking about how we use evidence to make decisions in our own work, what some of those barriers might be, and some of the solutions that we've come up with that have made evidence work for us. We'll then have a few case study examples, and we'll finish off with the question and answer session. But if you do have any burning questions throughout the sessions, just pop them in the chat and we will endeavour to answer them as we go along. And then finally, before we start, I would also like to introduce and just thank the brilliant facilitators that we have on board today. Without their expertise, this would not be possible. I'd like to welcome Miranda Cumpston from Cochrane Public Health and Monash University, Tari Turner from Cochrane Australia, Monash University and the National COVID-19 Clinical Evidence Task Force, and Kat Lane from the National Centre of Implementation Science and Hunter New England Population Health. So I'm just going to start with a little bit of background about what research evidence is and how we might like to think about using research evidence to make policy and practice decisions. So evidence itself is pretty broad. It can include any kind of information that we use to help us understand something or help us to make a decision. And from a policy and practice perspective, that can include expert opinion, case studies, panel recommendations from panels of experts, anecdotes, case law, as well as research evidence. So as you can see, research evidence is just one small component, the types of evidence that can be used to make policy and practice decisions. And what defines research evidence is empirical data that we collect through systematic procedures to answer and try and understand some kind of phenomenon. And it's quite an advantageous it has a lot of advantages to using research evidence to inform our policy and practice decisions, as it's objective, or it should be objective. We can use research designs and methods to try and reduce the influence and impact of bias. We use systematic and transparent methods, which are capable of replication, which hopefully increases our confidence in the evidence that we are obtaining. And usually they go through quite a scrutiny through peer review, and a lot of questions are asked about the methods we used, which hopefully does increase the trustworthiness of the research evidence that we do get. So this is obviously the ideal situation, these strengths, but this is why we do emphasise the use of research evidence to help us inform our policy and practice decisions. There is a wide range of type of research evidence that we can use and we can draw on, and these are some very broad labels. So obviously we can get quite specific, but this is just to give an overview of the different types of research evidence that we can use and we can produce. And this can range from things like quantitative evidence, which includes survey results, administrative data, modelling, which is where we use mathematical equations to simulate scenarios and make predictions, cost or observational studies. There's experimental research evidence, which is where we test the intervention or something that we introduce to see if it has an effect on a desired outcome. That can be either randomised or non-randomised. There's qualitative evidence as well, which is non-numerical, and we collect that through focus groups, interviews, observations, and then synthesis, where we try and bring together all of the evidence on one particular question and combine and summarize that to get an overall understanding of a particular phenomenon. So as you can see, there is a wide range of research evidence that we can draw on when we're making a policy or practice decision. And one of the difficult things can be in deciding which is the most appropriate, or what type of research evidence should we be using to help make a particular decision. So I don't know if everyone's familiar with the evidence hierarchy or pyramid, but this was drilled into me when I first started in research as what we should be looking at in terms of creating and using evidence for policy and practice. The concept was that those research studies or the designs at the top of the pyramid were of the highest quality, and that's what we should be aiming to use, whereas those towards the lower end of the pyramid are of low quality and we should be trying to avoid them. This is actually quite a limited schematic in trying to tell us about what research evidence we should be producing and using, because these types of designs don't always answer every single question. It also doesn't give us the broad range of evidence or information that we might need to try and answer a particular question or make a particular decision. So I think the first thing we need to think about when we're trying to decide on what kind of evidence to use or create for a particular policy or practice decision is what's the specific question we're trying to answer. And these are just a few examples of some of the main questions that we come across when we're making a policy and practice decision. And the first is about understanding the problem. Some of the questions that we might ask in relation to this is, how big is a particular problem? Does it differ for different people or different situations? And how do people experience the problem? The second, and probably one of the most common that we hear about a lot, is how best can we address the problem? So what interventions, what strategies, what solutions can we use? And this includes questions such as what works, what are the harms, what are the cost and resource implications, and do people find the possible solutions acceptable? And then finally, one of the main questions we do ask is about how do we implement a solution when we have one that we want to promote and use? And this will include sub-questions such as, how do we promote the uptake of the solution into practice? And what are some of the barriers and enablers that we might need to address to implement a solution? So just to demonstrate how some of the different forms of evidence might be used to answer some of these questions, if we take the question, how best do we address a problem? We can see that for what works, we can use experimental research evidence, we can use quantitative evidence with well-designed observational studies, and we can use synthesis. But if we're trying to understand whether people find a particular solution acceptable and feasible, experimental studies probably aren't going to answer this question. We're going to need different types of research evidence, such as quantitative surveys, qualitative evidence through focus groups, interviews and observations, and again, synthesis. And I would like to highlight the importance of evidence synthesis. This can be used hopefully in most, to inform most policy and practice questions. And it is usually looked at as a higher form of evidence because it's bringing all of the data or all of the research evidence across relevant studies together and summarising that using systematic and transparent process. Provides an overall understanding of a particular question, and it doesn't just rely on one single study. It can also show replication of results. In that way, it can build our confidence in the evidence that we're seeing, and it can allow us in some cases to look at how things might differ across different samples and settings. And while it is advantageous, there are barriers to using evidence synthesis. And some of the top barriers that we do encounter, particularly when making policy and practice decisions, are just the large number that are available at the moment. They can also be narrow in scope. So often there might not be a particular synthesis available that's answering your question, or it might not answer or offer evidence that you need for the whole question. They can be in varying quality, and it can be difficult sometimes to distinguish between high and low quality syntheses. And they often, or they can take a long time to produce and then publish and get into the public domain. So by this time, sometimes the evidence that is available in these syntheses is not up to date. And they might not include all the necessary evidence that we need to make a particular policy or practice decision. So just wanted to end this part of the presentation with some tips for identifying high quality syntheses. The first thing is, if you can, if it offers evidence synthesis that's appropriate for your question, look at the source. So reputable sources such as Cochrane, Joanna Briggs Institute, or the Campbell Collaboration. Also assess the conflicts of interest and who might have funded the work. I'd also check whether the methods have been pre-registered or whether they use key methodological indicators for higher quality, which is things like, did they grade the quality of the evidence using recommended approaches such as grade? Did they assess the quality of included studies? And did they report results in accordance to recommended guidelines such as PRISMA? In terms of looking for up-to-date evidence, we are seeing more living syntheses. So these are syntheses that are done rapidly or frequently, updating the evidence more frequently as it emerges. And this is most likely related to topics where the evidence is emerging and improving rapidly. And also search for specially designed databases for evidence synthesis, such as the Cochrane Library, the Joanna Briggs Institute, and Epistemodicus. And then finally, once you have your synthesis, just a few tips for interpreting, because they can be quite difficult. First, I would look at whether it addresses the specific question that you're looking at. And you do this by checking the objectives and the eligibility criteria. You can also assess the quality of a particular review using some tools that are available, such as MSTAR and Robus. And also looking at the results then, once you've got a review or a synthesis that's relevant to you, how certain are you of the results? And if it's high quality review like Cochrane, they'll often use the grade approach or the grading of recommendations, assessment, development, and evaluations to rate the quality or the level of confidence that they have in the results that have been produced. And they'll assess these important indicators that we know do impact on the quality, such as imprecision, inconsistency, indirectness, and publication bias. So that was just a initial overview of the definition of evidence and how we might like to think about it when we're thinking about using research evidence to inform our policy and practice decisions. I'm now going to hand it over to Miranda, who's going to now touch on actually thinking about it from the policy side of.
Okay, hold on a second while I see if I can make sure you can see the right part of my screen. How's that looking? You see okay? Great, cool. Okay, thanks everyone, and thanks Alex for the intro. So I guess the next step in how we think about all of this is starting to step from thinking about what the research evidence is to thinking about how it lands in the policy world. And I know that our audience today can be, you guys have all got different backgrounds and different roles. So some of you might be more up the research end, some of you might be more up the policy end, and some of you might sit right in the middle in that space of translating research into policy. So I'm sure some of you will know more about this than I do. But let's start with what we mean by policy in this sense. And I think about it pretty broadly. So sometimes we talk about policy being government decision making, and that can happen at all levels of government, from national announcements by the PM today about COVID through to what the local council might be doing in terms of parks for kids or what the school system is doing. But we also mean anyone who's really setting policy at a level that's, a step up from decisions about an individual person's clinical care. So we might be thinking about health service managers, NGOs, commercial companies, a really broad range of people who might be thinking about what they should do and who we would ideally love to be taking evidence into consideration. So a really sort of straightforward conceptualization of what we mean to get evidence into policy is, we might have some hopefully really useful research evidence, and we might really want someone in the policy space to take that evidence and act on it in practice. So implement the policy about, everyone should be getting this care option. We should fund the care option or implement this program in schools, whatever the next steps of action might be after we think we have an answer to a research question. And there's starting with a really kind of simple way of thinking about this. There's a lot of thinking that's gone into this from very many authors over the years. So, but that some of the terms that we use to talk about actions we can take to encourage evidence to be used in practice are these terms: push, pull, and exchange. So push is when we talk about people from the research side of things disseminating and communicating their results. So they might be publishing it, they might be publishing policy-oriented summaries, they might be speaking with decision makers, making submissions to formal processes, talking to the media, just getting the results out there so that people know it exists. What we mean by pull is that is steps that we can take to have the policy decision makers themselves seek and pull the evidence into their decision making. So that might be about setting up infrastructure so that they have easy access to the research. It might be about training and skills and knowledge to help them understand what might be out there. It might be personal relationships. It could be a whole range of activities. Exchange is kind of a next level of complexity, and it acknowledges more that there's different knowledges and different expertise on both sides of this equation, from the policy perspective and from the research perspective. And that sometimes what we need is not just to push or to pull the evidence, but to have a conversation about it and work together to work out what the decision-making needs are of the policymakers, what the context of the research is, and how perhaps those two things can be brought together in a more collaborative and two-way exchange. And I think that kind of gives us a hint that that there are two perspectives here and two really important areas of expertise, which I'll talk about a little bit more, to think about not just what the research is and what decisions it might imply in a straightforward way, but how it might fit into quite a complex perspective of policy decision makers. And as Alex was saying, some of it comes down to, if we, even if we're thinking about it from a policy perspective, some of it comes down to what kind of questions we're asking. So just like researchers might have questions about the effectiveness of an intervention or the scale of a problem, policymakers will also be thinking about exactly the same thing. So they may have a question that needs answering, and they may go to evidence of various kinds to answer that. So that could be so for example, if we're talking about dental health, we might be wondering who's at most risk of having poor dental health. Is there a way of finding those people? Are there any early detection mechanisms we can use or screening we can do, say, of young kids in schools? What kinds of treatments or interventions might we use? And that might be anything from people going to the dentist to fluoride in the water of a whole population, to encouraging people to use fluoride in their toothpaste, putting fluoride into other kinds of products. There could be all sorts of different levels and scales at which you might act and choices between those options. And then so you'd like to know, ideally, from a policy perspective, what the different impacts of those are going to be: positive, negative, cost-wise, before you make a decision. And those decisions, as I'm sure many of you know, can get much more complex than a straightforward decision to act on a health intervention or not. And so this diagram is actually one I sketched out when I was working on a water quality project, just to help myself make sense of the context of the decisions that were being made. So we're talking about, not just about interventions you might make to ensure that drinking water is of a high quality, but you have to think about the water. Where's it coming from? How is it extracted? Is it rivers? Is it aquifers? Is it, bore water in the desert or rivers in the tropics? You have to think about the environment it's interacting with. So rocks, soil, leaf mulch, all sorts of other contaminants in the environment, and the climate around its storage of water. What we're storing it in: dams, tanks, distributing it through pipes, trucks, And that's all before you interact with any humans in that process. So only then can you start to think about what the effects of consumption or exposure to water with different contaminants might be, and then what the health outcomes might be. And you might be looking across geological science, chemistry, a lot of lab science, and then animal studies, longitudinal epidemiological studies, and so on, and trying to integrate all of that evidence to make a decision about what should be done, to like what the decision should be about what the best approach is throughout that system, throughout that process. So the decisions can be really complex, and it's not always just a straightforward question of should I do X or Y, but quite a complex framework of thinking about any kind of action. So Alex also touched on what different kinds of things we might consider evidence, and that put me in mind of a study I did quite a few years ago now with some colleagues, where we ran some interviews with staff at the Federal Department of Health. And it was interesting to see the different kinds of things they meant when they were talking about evidence. And very similar to what Alex was saying, we found that sometimes they were talking about administrative or routinely collected data, you know, all the Medicare data they have or the PBS data. Sometimes they were talking about reviews and evaluation reports that might be done internally. Sometimes they were looking at reports about examples of what had happened in other places, or direct feedback from the community or members of parliament, ministers, their staff, as well as the different types of research evidence that we talked about. So qualitative, economics, burden of disease, the effects of an intervention or the accuracy of a diagnostic test, all of those things might be of interest, and they might help you both work out what the problem is and consider what the solutions to it might be. So this is just one study that we did, but that echoes very much the findings of a large number of other similar studies in different jurisdictions. So I'm going to give you a few examples of different frameworks and approaches today, but these are very much just sort of examples of this field of research. So if you're interested in reading more, there's a lot more out there, a lot more examples, and also systematic reviews of research with policymakers. So one framework that might be quite useful, Alex mentioned GRADE in terms of assessing the certainty of the evidence in a systematic review. And GRADE also produces this larger framework called the Evidence to Decision Framework, which is intended to be used in making decisions in clinical practice guidelines. So based on the evidence of the effectiveness of an intervention or the intervention options for a particular condition, what practice should we recommend to clinicians? But it's quite a useful sort of quick summary framework about all the different some of the other different aspects that you might need to take into consideration when you make a decision. So it's not just a straightforward matter of, yes, this works, okay, therefore we should do it with everyone. But we also need to take into account the balance. So the weighing up the pros and cons of the different possible beneficial effects, but also the harms of different interventions. We need to consider resources. So how much is this going to cost? What kind of staff do we need to implement it? What kind of time is required? What's the relative cost of the different options available? Any other resources that might be needed? So machinery, other equipment, testing systems, all sorts of different components of the health system or whatever system you're working in to implement the intervention. You need to consider the impacts of equity questions. So will this work for everyone, or are there some people that it won't work for? How will it affect the existing inequities in the health system? So will it be really great and wonderful, but only for those people who can afford to follow these guidelines? Or are there disadvantaged communities that will have different effects or different impacts of this intervention? Is it acceptable? So will people go for this option? And I think, you know, those kinds of cultural and values questions are really important to consider as well. And flat out feasibility. So can we get it done? Is it even legal to to introduce this option that we think might be effective? You know, so that's just I find that quite a useful framework although it was designed for this particular context of clinical guidelines, I find it quite a useful framework, just as shorthand, a reminder of some of those different factors that that need to go into decision above and beyond what the research evidence might say. So to take that into a more specifically policy space, so this framework, the Spirit Action Framework, was developed a few years ago, including Tari Turner, who will be speaking to you in a moment, as one of the authors of that. So full credit to Tari for doing the work that I'm now taking advantage of. But this framework is really designed to help think about both how policy decisions get made and also how we might think about acting to influence that process, and how we might think about any interventions that we might want to take to encourage changes to policy decision making, to perhaps increase the use of evidence or consider different factors in that decision making process. This is part of a larger diagram, which I'll come back to shortly, but it just summarizes in this section the policy influences that impact on every policy decision that gets made. And it's really important to recognize that these aren't just kind of inconveniences or things that shouldn't be taken seriously, because they, public opinion and the media really do reflect sometimes the concerns, the acceptability of what's being proposed, and the values of the community, which are important to take into account. The economic climate speaks to feasibility and resources, and the relative priorities of different actions that might be taken. Legal frameworks, political ideology is very important. As we will have seen some important changes in government policy with the recent change at the federal government level. The interests of different stakeholders, which the members of the public may have very different perspectives, from healthcare providers, from commercial interests, from different professions that might be involved in the delivery of a particular decision. So there's a lot of different factors that need to be taken into consideration. I find this framework also quite useful because it speaks to the kind of triggers and the reasons why the decision is being made. So not only why you make a particular decision about an option to be taken, but why you're even asking a question in the first place. And it's not necessarily just an academic exercise or an intellectual interest. There are catalysts or triggers that can initiate the process that might require a policy decision. So it may well be that they've heard about some fantastic new research findings and they'd like to decide what to do about it, which is great. But there may also be important external triggers, such as, I'm sure Tari will tell us a lot more about how COVID and the pandemic triggered some policy work. But also, sometimes policymakers are required to provide a recommendation for a decision of government or another reason. They might, in some ways, just to flip that a bit, they might need to identify evidence to support a recommendation or a decision that's already been made by government in terms of communicating the rationale for why that decision's been made, which is a different framework for deciding what decision to make. They may be using research as part of a program to try and persuade the public or other audiences of a particular position. Sometimes it's really pragmatic, like, it may be that the end of the financial year is coming up and there's some unspent funds and they need to decide what to do with it, which sounds crazy, but sometimes it's something as simple and practical as that can give an opportunity for a discussion or a decision to be made about actions that can be taken. So those are quite different ways of using research. So just looking at those outcomes research use, that box on the right there. So we can talk about the research being used in different ways. So sometimes it's about policy development, making decisions, but also sometimes it's about agenda setting. So it's about what questions are even on the table to be discussed, let alone what decisions we make in response to that. It might be about monitoring or evaluating a previous decision that has already been made, or it might be about thinking about how to implement something that we know is a good idea, which is a field of research in itself. And sometimes that research is being used how we might initially imagine it, so that we have a question, we find the research, we make a decision. But sometimes it's being used in a more tactical or strategic way to persuade or to influence. Sometimes it's being used because it's a requirement of the policy process. So it's imposed on the policymakers, which can be a great thing where you can have that built in. So there's a lot of different ways in which policy decision making can or does access and use different types of evidence. But it's only one part of a very big picture, quite appropriately so. And it's also can be quite a diverse range of different ways in which research is being used. So I'll leave it at that for now. And Alex, do you want to move on to the small group sessions?
Yeah, no, that would be great. Thank you so much for that, Miranda. So hopefully that gives us an idea about what research evidence is and how we can create it, but also from the perspective of the policy, so how we might be using it to inform policy and practice decisions. So the next thing we're going to move on to is the small group activity. So we're going to break up into groups, and each of the facilitators will be in that group. We're just going to talk about people's experience with developing or using research evidence to make a policy or practice decision. What were some of the barriers, and also what did you find useful? Like, well, how did you make it work? And then we'll reconvene in about 15 minutes. Do we have everyone back? Okay, great. I think we have everyone back now by the looks. Thank you so much. I know our group just had a great discussion. I think we could have kept going. And I'm so sorry, Britt, we were halfway through. We'll have to touch base afterwards. I might hand back to Miranda, who's going to summarise what we just did and link that back to some of the frameworks that she was talking about before. Oh, I think you're still on mute. Sorry, Miranda.
There we go. Thank you. So hopefully we all had a good discussion. We had a pretty good, brief but useful discussion in our group. And so we discussed a number of different barriers and facilitators that come from people's experience working with different departments. So some of the things that we mentioned included the short timeframes that are needed by policymakers to make decisions that didn't necessarily fit with research timeframes. That also policy decisions were often looking for short-term measurable outcomes rather than very long-term interventions, such as in obesity that might take a long time to be evident. We talked about resources, so resources to support either evidence that didn't exist being commissioned or resources to support larger scale up of interventions that might have been proven useful. We also talked about the need for cost effectiveness data as well as effectiveness data, and the values and whether evidence was valued or prioritized within the policy organization, whether leadership was encouraging that. That all came up. And as a facilitator, we talked about as well the importance of being able to communicate very briefly and clearly what the bottom line is of the research. So I don't know if anybody else wants to chip in additional things that we didn't cover there that came out of any of the other small groups. If anyone wants to speak up, please do. I can't see hands up.
Miranda, it's Tari. Can I just jump in?
Yeah, please.
I think the other thing that we came up for many of us in our group was just the real value we found in working together with people who've got different perspectives, like the researchers and the policymakers coming together, and consumers or others from outside that as well.
Yeah, great.
And I'll jump in, Miranda. One of the things that came up in our discussion was the connections, like having those good relationships, which I think sort of adds on to Tari's point, and the trusting, like being trusted by like people in policy and practice and also research. So having like trusting relationships and building those.
Mm-hmm. Any other critical factors we've missed? Anyone want to jump in?
Our group had basically the same things, and a big one was government prioritization. So sometimes even having the correct evidence and having robust quality evidence and having it disregarded just because it wasn't a priority. And then, yeah, everything else you guys said, the funding and the timeliness.
Great. Thank you for that. I guess all I can say is all of you are very clever and know a lot about this already. So completely unsurprisingly, a lot of the things that we can pull on from our own experiences, either as researchers or working more in a policy space, across the research that you'll find in this field, all of those things come up in the different summaries and projects and frameworks that summarize barriers and facilitators to policy and to evidence-informed policy. And so these are drawing on that same spirit framework, but just pulling out some of those factors. So the external factors, so deadlines, political priorities or government priorities, legal constraints, media. So those factors about what's acceptable, what's considered a priority at different times can be really important to what decisions are being made and what information is going into them. The availability of the research, so if it doesn't exist, you can't use it. Perceptions about the value of research in policy, which might vary in different places. decision makers having the knowledge and skills to both identify and to apply the research to the decision-making process is really important. That engagement and relationships, communication between the different stakeholders involved with the researchers, the policy decision makers, other stakeholder groups like consumers, really influences not just a particular decision, but it can influence what research is conducted and how it's conducted, as well as how it might be incorporated into policy. And so it's a real two-way or multi-directional street. Organizational policies, leadership and systems. So how well research might be integrated into routine processes for decision making in different organizations, and just flat out the resources to access the research. So can they find it if they want some, which can be a real challenge. So a lot of those came up. So I think that kind of tells us that we all have at least some sense of what are going to be the important factors in these relationships, and and what might make for a more successful interaction or a more successful ongoing relationship. So just to bring us back to our framework here, this is the Spirit framework again, but the full version this time. So this framework has the kind of overarching influences that are influencing this whole process from conception to decision. In policy, we've got the catalysts that might instigate a policy. My laptop's having battery issues, so if I get kicked out, I'm very sorry. The capacity of the organisation, the staff to value research, the tools and systems to support it, different engagement with research, whether it's accessing it, appraising it, those relationships with researchers, the different ways in which research might end up being used, and underneath this all, the availability of research that's relevant and reliable to support each stage of these decisions, which hopefully would ideally end up with good decision making, research informed decision making, and so on. So just finally, there are a lot of resources that are relevant to this, but a couple of websites that might be useful to explore if this is something you're interested in looking a bit more about. The Sachs Institute in Australia, the National Collaborating Centre for Methods and Tools in Canada sounds a bit dry, but has a real focus on evidence-informed policy. The WHO's Ivamectin initiative, but also your own network of colleagues. I'm sure that you all have extended networks in your own institution and across your networks like those you're building at this session today, who have experience and expertise in these areas. So I encourage you to reach out and talk about it in the context of your own work. So that's everything I wanted to say for now. I'll hand back to Alex.
Thanks, Miranda. That was fantastic. And like really good, sounds like really good discussions as well, which was really great. Just share my screen again. Just make sure. Okay, can everyone see my screen? Yep, okay, perfect. So just like leading off on some of the theory and backgrounds that we've been covering, I'm now going to share with you an example of how we've used and generated research evidence in the past to inform our service delivery. And so I'll start with just a little bit of background. So I work with Hunter New England Population Health, and it employs a research embedded model of service delivery. And this is where we have researchers and service delivery practitioners who are working together to develop and deliver evidence-based health services. The specific team that I'm working within are funded to support schools in our region to implement obesity programs and policies. And the specific example that I'm going to focus on today is our current service delivery model, Physically Active Children in Education, or PACE, which we've developed to support schools to follow a mandatory physical activity policy. So in New South Wales, the Department of Education mandates that schools deliver 150 minutes of physical activity across the school week. And what we've actually found from research that's available through surveys and also our own service delivery is that less than 20% of schools were complying with this policy. So we identified a problem that we had and that we needed to address through our service delivery. So once we knew that we had a problem, we wanted to investigate whether we had any viable solutions that we can incorporate into our service delivery model to adequately support schools. So the first step that we took was to conduct a systematic review and to see whether or not there were any effective and relevant support strategies that we could use within our service delivery. But what we found that there were none, so we had this evidence gap. So the next step that we took was to try and generate our own evidence to test and develop support strategies that we could incorporate. And the first step that we did for this was to try and understand what the barriers and enablers for schools and teachers were, and to ask ourselves, like, why? What's impeding them from delivering 150 minutes of physical activity across the week? And the first step we did was to conduct another systematic review to look at the barriers and enablers. And this gave us like a global sense, because obviously this covered schools and teachers across the world. So we didn't restrict by country. It gave us an understanding of what might be the main issues that are impacting schools' delivery. But we also wanted to take a local focus, because obviously we're supporting schools within our region. So we wanted to make sure that the service delivery that we were providing was adequately addressing the specific needs of our schools. So we undertook surveys with teachers, principals, and school staff throughout our region to better understand what the barriers and enablers were for them. Once we had this information, we started to develop a multi-strategy support program, or PACE, which is our current service delivery model. And we developed this through a multidisciplinary team. So we had implementation scientists, teachers, service delivery personnel, members of the Department of Education and Catholic Schools Office. And we did this through a theoretically informed framework. So we took all the barriers that we had gathered through our systematic reviews and surveys, and we mapped them to different strategies that had evidence of being able to create behaviour change. We also had to look at strategies that we could deliver within our resources that were available from our local health district. And what we came up with was a multi-strategy support system that contained 8 different strategies that are shown on the screen there. So once we'd used the evidence that we both had available and generated to develop our PACE model, we then wanted to test it to make sure it worked, to make sure it was feasible to deliver, but also that it was acceptable to the schools and the teachers that we were trying to support in the first place. So we did this first by running a range of experimental studies, and we started with a small pilot with just 12 schools. So 6 of those schools were randomised to receive the PACE program, and 6 were randomised to just usual support. And we looked at things about, like, was it feasible to deliver within our resources? Were schools accepted of the program? And did it seem like it had an effect? And we did find an increase in scheduling. We also found that schools were really receptive and really acceptable of this proposed program. So taking this information forward, we then updated the PACE program slightly based on what we'd learnt, and then we ran an implementation trial to assess the effectiveness of this program. So we had 61 schools, and half of them received the PACE support system, and the other half had usual care. And again, we had an effect. So we saw an increase of about 40 minutes, just over 40 minutes, in the scheduling of physical activity in those schools that received PACE. We also looked at cost as well, because this is a really important piece of information that we need from a service delivery. Obviously, we only have a certain amount of funding to be able to provide the support, so we needed to make sure that fit within our budget. And we had promising results from that as well. We then moved to scale up. So we wanted to see whether or not we could deliver this program to a wide range of schools, but also we wanted to engage with other local health districts as well, and to share, I guess, the information that we had collected and the evidence we'd collected to see whether or not it was acceptable outside of our region. So we engaged in a large scale-up study with 100 schools across 3 LHDs, and we found again that we had successful increase in scheduling of physical activity minutes of almost 30 minutes. And we had high acceptability from the teachers and schools that we reached out to. And then the last study that we've done so far is an optimization trial. So in our larger implementation trial and moving into scale up, one of the things that we were considering were our cost and our resource constraints, and the possibility that if this was going to be a model that went beyond our local health district, that we might have to make some tweaks and reduce some of the more resource intensive strategies. So we adapted some of our PACE strategies to make them lower intensity and lower cost. And we ran another randomized control trial to see whether or not this adapted model was effective. And we found it was 96% probability of having a similar effect to our original model, which is great. And it was also a lot lower in cost as well. So we examined cost here. And this is the current model that we're using within our local health district to support schools to schedule physical activity and comply with that mandated Department of Education policy. So what you can see is that this process, it was very iterative, but we did pull from a large range of different research evidence to inform what the practice was that we're delivering. We started with quantitative research, which involved surveys to identify the extent of the problem and that there was a problem. We used it to also establish barriers and enablers that we might need to address, but also to look at the acceptability of the proposed solutions that we were testing. We drew on synthesis evidence as well, so conducting systematic reviews to see whether there were any solutions that were reasonable, effective, and acceptable for our setting, but we didn't find that. But we also ran systematic reviews to look at the broader range of barriers and enablers that we might need to consider. We then ran a range of experimental studies that gave us experimental research evidence, so evidence on the effectiveness of our strategies. And we also embedded qualitative evidence as well within our experimental studies to look more deeply into the acceptability of the strategies, how we might improve them, whether they were appropriate for different school settings, and then also cost. So I think this was a really important piece of research evidence that we needed to consider because we're obviously constrained by a set budget. So we needed to make sure that we could deliver something that was effective, appropriate, but also within the resources that we had available. And I think just touching on the frameworks that Miranda had just spoken about in terms of strategies to try and help with that push, I guess, that push strategies of when you're generating evidence and trying to have that evidence inform policy and practice. Some of the things that we embedded to try and make that the case here, we had obviously the advantage of an embedded service and research delivery model. So the research we were generating was directly informing our policy and our practice here. I think the fact that it was an end user identified problem, so we knew it was something that we needed to address. It was part of our work. And so I think that drove our research from being generated and then implemented into practice in a relatively short time. We also drew on multiple types of evidence, so not just relying on experimental or randomized control trials, because that wouldn't give us the whole picture of what we needed to know to be able to incorporate this as part of our service delivery. We also drew on a multidisciplinary team. So we had not only like our service delivery policy implementation scientists, we also had health economists, statisticians to ensure that we were developing the appropriate evidence, but also to a quality that's acceptable and also like gives us confidence in the results that we were getting. And the next steps we're doing is actually trying to push this out and roll this out to other LHDs. And one of the things that we're using to do this is a variety of dissemination products. So not just the traditional academic dissemination through publications and papers, but things like engaging with other end users, setting up meetings, having presentations that are specific to our other colleagues, blogs and infographics, which I think has been a real help in terms of trying to move this evidence into real world practice. So that's just one example of how we've used generated evidence to support our policy and practice here at Hunter New England. And I'm hoping it provided some ideas of how that can be done. And I'm now going to pass over to Tari Turner, who is going to share with us another case study of how evidence can inform policy.
Hi, everyone, and thanks, Alex. I'm hoping that you're seeing my slides now. Thanks for the opportunity to come and chat to you today. I'm very grateful to come and reflect on these things with you. This is one of my favourite areas of work, actually, is this space between evidence and real-world impact, particularly policy. Miranda and Alex asked me to join you today and to talk to you about the challenges that we've been facing in the National COVID-19 Clinical Evidence Task Force. And my initial response was to politely decline on the grounds that we actually haven't had that many challenges. But then on reflection and further discussion with Alex and Miranda, we realised that in itself is a useful learning experience. So today I'm going to tell you a little bit of a fairy tale, essentially, about the task force and the work we've been doing, about some stories that highlight what it can look like when it goes well, and then to reflect on what's been a bit different about the COVID example that might underpin some of this conversation. So I'm going to do a whirlwind tour of the COVID task force just to give you the background context, and I will move pretty quickly. And a little bit of an introduction to what living guidelines are and the work that we've been doing. And then I'll tell you some stories about our experiences that highlight some of what has been a really positive and encouraging experience. So for those of you who aren't familiar with the task force is a collaboration of 34 peak professional bodies that represent all the people who are involved in providing care for people in Australia with COVID-19. We develop living evidence-based guidelines that guide care, treatment, management and care, not prevention or vaccination, but just the treatment elements. And we do that using continuous evidence surveillance that I'll talk a bit more about in a few minutes, to find new evidence as it emerges and to provide a single unified clinical voice for guidance for clinicians. So this is our membership organisations. I'm just so waiting for one more group to join so that we can have that box down here filled in, but you can see it's a really diverse group from the colleges of surgeons and GPs, midwives, nurses, infectious diseases physicians, the whole spectrum. And I just want to note too that we've been supported by a broad collaboration, and particularly to note that our funding has come from two political sources, essentially two government sources, Victorian and Commonwealth government, as well as philanthropy. Oops, excuse me. So essentially the plan at Task Force is that every week we look for any new evidence that's come out. We evaluate the quality of that evidence, we synthesise it and develop new recommendations or revise our existing recommendations to reflect that new evidence. And in fact, we undertake searches every day. When I wake up in the morning, there's new evidence in my Slack stream to tell me what we might need to incorporate into our guidelines. We then have several large panels of clinical experts who review this evidence and make new and updated recommendations, which we are then endorsed by those 34 membership groups and published online. Just to give you a bit of a sense overall, so we have an evidence team of evidence synthesis experts who undertake those evidence reviews and produce reviews and flowcharts. Then we have 6 panels of clinical experts, everybody from primary and chronic care representing our GPs and pharmacists and so on, pregnancy and perinatal, paediatric, palliative, the whole spectrum. And importantly, and as we mentioned actually in our small group, we've also have a consumer panel that advises on all of our work. These panels draft recommendations, which then go to a guidelines leadership group, which is our highest level of clinical review, and are then approved by our steering committee. So many of you will be familiar with the idea of clinical practice guidelines, and conventional approaches to guideline development recommend that those guidelines are updated about every 3 to 5 years. What's different about our work is, of course, that we don't have that long between updates of our reviews, and in fact, they're updated on about a weekly basis. Sometimes it's a fortnight. So we talk about traditional guideline development as walking a mountain. You define the scope of the guideline, you undertake the evidence reviews, you develop the recommendations, you have them approved, you publish them, and then over time, those recommendations become increasingly outdated and unreliable. In a living guideline model, we undertake the same process to develop the initial guideline, But then rather than letting those decay in relevance or recency, we say we walk across the plateau and we continue to update the guideline over time using exactly the same methods, just at a more rapid frequency. Miranda touched on grade methods before. So these are the standard rigorous methods for assessing the quality and reliability of a body of evidence, and we use those approaches. So it's a systematic and transparent method for appraising the reliability and confidence we have in a body of evidence. And these are used in lots of other contexts too. But I guess the point of this slide is really to highlight that we're not cutting corners in terms of methods. We're doing a full rigorous approach, but we're doing it quickly. And then once the recommendations from the guideline are republished, our comms team goes into action, and the recommendations of the COVID task force are published on our website. They're pushed out in a newsletter. We're on Twitter, Facebook, and LinkedIn. We have a range of internal networks, and our members push them out through their newsletters and other contacts. And we've been undertaking interviews and doing press releases, and there's a whole big push on dissemination. And I hope that some of you will have seen our work in various places around over the last 2.5 years. I think what's interesting to me is that 2.5 years ago, we really didn't know anything about how to treat COVID. And there's been a huge amount of evidence generated subsequently. March 2020 seems like a long time ago, but many Australian clinicians were quite nervous at that time about what it would mean to treat a patient with COVID. They'd never seen a patient with COVID. And being able to provide guidance that continued to develop and reflect the best available evidence at every time over the last 2.5 years has been something that has been, I know, a real comfort to them. But today we're going to talk a little bit more about the policy. And so just to give you a starting point of where we are at now, some numbers. So as I said, 34 peak clinical bodies involved in the task force. We have more than 200 clinical contributors representing all those different professions. We've had 102 updates of the guidelines, 103 goes live tonight, supported by a range of tools for disseminating the results of that process. We estimate that that process has been enabled by 25,000 plus volunteer hours from all our clinical experts. There are now 180 recommendations based on evidence and consensus in those guidelines, including more than 20,000 studies that have been reviewed. And they're having a wide impact. We've had more than 1 million page views of our guidelines, and we know that there's more than 500,000 users. So in this context, that I want to tell you a little bit about the policy connections the task force has. So built into the process has been strong connections, particularly at the Commonwealth Department of Health. And I think actually that connections in at the local jurisdictional level at each of the states is an area that we want to grow and develop. But for example, some of the groups that we liaise with regularly include the Office of HTA, the PBAC, TGA, medicine shortages. There's a Living with COVID task force section within the Commonwealth, and the Chief Medical Officer and Deputy Chief Medical Officer. And we've been in the fortunate position to have established a fortnightly meeting, which is a cross department with many of the representatives of these groups that have enabled the conversations that I'm going to tell you about. So I thought I'd just tell you 4 little stories that give a bit of an insight into the way that we've worked with policy and the positives and negatives of that. So the first time this really occurred to me, the impact on policy that our guidance was having was in the context of a drug called budesonide. So many of you will be more familiar with budesonide than I am, but it's a widely used drug that's often used for conditions such as asthma. And a trial came out that showed that it was effective in reducing some of the symptoms of COVID. And so on a Thursday night, we published an update to the guideline and sent out a communique noting that we'd made a recommendation for the use of budesonide in a certain group of patients. On the Friday afternoon, we received a call from a colleague in the New South Wales Department of Health asking if he could have advance notice in future of any of these types of recommendations. And when we asked why, he said that he read the communique that we'd sent and gone to the National Medicine Stockpile to order budesonide for New South Wales, but that when he'd got there, Victoria had already soaked up all the stock. And it was really at that moment that I realised that people were reading our guidelines and that it was having an impact on the kinds of decisions people were making at a policy level as well as a practice level. And in reflecting on this experience, which is one that we're trying to avoid in future, we certainly don't want one state getting all the stock of drugs that are useful and important for COVID patients. We reflected on the fact that it's actually much easier to develop guidelines when you know no one's reading them. There's a certain pressure that comes with putting out a recommendation on a Thursday night that's going to have implications at a national level for stock of a drug on a Friday. I think also another story that I want to tell is in the context of infection prevention and control. And of course, 12 months ago, there was a great deal of angst about what types of personal protective equipment healthcare workers should be used and should be supplied with. It's almost an evidence-free zone. In fact, we did a systematic review where we scanned more than 11,000 articles to try and find reliable evidence to inform that decision. And there's very little evidence to help choose, for example, between two different types of masks. So in the absence of evidence, we were able to convene a large, very multidisciplinary group, which include all the usual clinical suspects, but also people whose job descriptions I'd never even heard of before, people who were looking at mechanical engineers, looking at hospital air conditioning designs and all those kinds of things, and come up with guidance that was based on consensus opinion of a very broad multidisciplinary group, which was then taken up by the infection control expert group in the Department of Health and has had significant implications, which has been great. The third story is really about what happened to me on Australia Day this year, where I was at a friend's house having a barbecue. And I received a call from Michael Kidd, who's the Deputy Chief Medical Officer. Now, I can assure you that up until that point, nobody had been ringing me from work on a public holiday, let alone the Deputy Chief Medical Officer. And I'll never forget sitting on the floor in my friend's study, talking to Dr. Kidd about how we could support the rollout of the recommendations we were about to put out, and the timing that would make sure that the appropriate Department of Health staff were in place to respond to them, and so that we could work together as one team and make sure that clinicians were all getting the same advice from the same people at the same times. And I think finally, just to kind of wrap up the stories, it's worth reflecting on the context we find ourselves in now with oral antivirals. So this is a situation where for the first time, there's slightly different messaging coming out from our friends at the PBS about the applicability of some drugs as opposed to the task force position. And we've been receiving questions about why our position is different from the PBS position. And without going into the details of that, I think what that's been highlighting to me is that people are reading our guidelines and they want to know why there are differences and what those differences are. And so that's been a real encouragement, but also a challenge. So in reflecting on why has my experience been different for COVID? Why has it seemed like in COVID, the translation of evidence into policy has been rapid and efficient and has been really desired? And that hasn't always been my experience in the past. I think there are at least three things that are different about this current context. One is the development of long-term relationships. So often in the guideline development world, for example, you'd spend 12 months creating a guideline, going through the process, doing the evidence synthesis, creating a guideline, and then you send it out to your policy colleagues at the end. And that might be the one time, or perhaps the second time, that you contacted them about the guideline. It's been a very different model that's been enabled by the living guidelines approach we've taken, which has meant that we have literally had meetings with them every fortnight. And so we've been able to develop some of that trust that people were mentioning earlier. We've been able to say, this isn't the end. We're not handing you a fait accompli. We're interested in your thoughts about how we can make this more useful and more relevant, and we can incorporate that into the next version that will be out next week. I think there's also no question that COVID has provided a context which is quite different from many of the other contexts in which we're trying to support the use of evidence in policy. And this intense shared focus and the high priority that COVID has had for clinicians, essentially every clinician across Australia has had to have some thoughts about the implications of COVID for them and their patients, has meant that it really has been a focus of attention, and all those things we've talked about before. You know, there have been the resources, it has been a priority. People are looking for ways to support clinicians to practice in the best possible way, and that has been a priority for everyone. We talked about this at Task Force, and it really has felt like we're part of one big team, all with the same goals. And I think sometimes we could perhaps reflect on that more broadly, because in health, we are all on one big team, and how we can take that away from COVID and build it into other sections, I think is a challenge for us. And I think the third thing is really this one voice we've been able to have. So the fact that we have all the colleges, all those expert groups, all the different specialities, all speaking with one voice, really has made it, as one of our policy colleagues said, pretty hard to argue So by both bringing up-to-date, relevant, reliable evidence that we know will continually evolve, and a shared consensus voice from all of those people, we've really been able to bring all those things together in one place for policymakers, and have made it so that policymakers haven't had to go out and do a whole range of consultation themselves, and haven't had to worry about what the other colleges might think, because we're all in the same place. This is just my slide to say I can't present on COVID guidelines and not say, please get vaccinated and wear your masks. And I'd love to hear from you. The COVID guidelines continue to develop, and we want to continue to make them better. So if you have any suggestions or thoughts about how we can make the guidelines themselves better, the dissemination tools better, or particularly how we can reach out better to those jurisdictions in other states, that would be really helpful, and I'd love to hear more. But I'll stop talking now. Thanks.
Thank you so much, Tari. That was so interesting. And I think like really highlighted some of the things that we spoke about in our small groups, particularly that building collaborations and like the groups, like having the co-production and the trusting relationships, and how important that is in terms of building evidence, but also translating it quickly into practice and policy. Thank you so much. We've now got a question and answer session. So if anyone has any questions for the facilitators, or any comments that they might want to make or share, please feel free, pop up your hand or pop it in the chat. I have one just to kick off. I know, like Tari, this is for you, just because I find this so interesting, because it is such quite a unique experience. But do you have any advice in terms of trying to pull together such a wide range of experts to be thinking and working on the same thing, I guess, on the same page, that we could take away for, I guess, obesity prevention or other areas that aren't under a pandemic, or the needs of a pandemic?
Yeah, sure. Happy to talk to that. And I think Bryony's asking a similar question in the chat too. So yeah, I can talk a little bit about how the task force was formed. So it was formed very quickly in March 2020. So many of you will know that there was quite a bit of work happening around living evidence at Cochrane Australia prior to COVID. So some of you will know the living stroke guidelines, which were the world first living guidelines. And there was quite a bit of expertise in the kind of living evidence synthesis methods within Cochrane. So we were able to pull together the kind of evidence team, what we call the engine room of that, quite quickly and spin it up. And then, yeah, the second part of that, as you're highlighting, Alex, was the pulling together of all these other clinical groups. And that came together very quickly. Essentially, you know, as the COVID pandemic was really starting to hit all the headlines, Julian Elliott and Rhiannon Tate reached out to all our contacts and all of those people and said, right, this is happening. Do you want in? And essentially everybody did. So we didn't have all 34 straight up, but we had more than a couple of dozen from the very earliest days. And it has been since that very early time that we've agreed that we won't publish anything unless we have full consensus across all of those groups. And it's not always that all those groups agree in other contexts, but I think one of the things that's been really encouraging to me is that we still meet regularly with all 34 of those groups, and we still have full consensus across all the guidelines. And I think there's, from the clinical perspective, in terms of the members of our panels, those 200 plus doctors, nurses, pharmacists and others, people have actually really enjoyed the process of coming together during COVID and sharing their experiences and being able to talk about what's happening in their hospital or in their GP clinic. We keep worrying that we're taking up too much time and trying to cancel meetings. And they're like, no, we want to talk. So I think there's been something really collegial about that experience.
So it's almost like finding that common thread and I guess inviting those conversations regularly. Maybe sometimes we hold on too long and don't invite people early and like build up that trust and that relationship and have that regular contact. Yeah, and there's definitely, we can't get away from the fact, right, that COVID was just a huge priority for everybody. Everybody wanted to know what to do and needed to know yesterday. So that was definitely a motivating factor. But we're also having conversations now as a task force, given this model works, are there other places that we could be using that same approach beyond COVID to provide guidance in areas of high uncertainty? Yeah. I think Kripri just put through a beautiful comment it's like business chemistry. Well, everyone is playing a different instrument, a different pitch, but producing a beautiful melody. I think that sums it up quite nicely.
That's lovely. Yeah, and it does feel like a choir, you know, there's a whole bunch of us all together. Yeah.
So we do have a question from Jane. So it's not for a particular speaker, but how do you respond to those who question the evidence? I previously worked in the immunisation field, and as we would know, many, including clinicians, question the science behind vaccination. It can be challenging responding to those who should be using the evidence to guide their practice.
Can I jump in? Because my immediate response to that is ivermectin. So many people know that ivermectin has been a really hot button issue during COVID, and people have been promoting its use for treatment of COVID and also for prevention of COVID and for all sorts of other things. And that's been an ongoing issue for us. So we've consistently said from the beginning that there wasn't enough evidence to recommend its use, and then that there was enough evidence to recommend it not be used. And I think that's been a tricky conversation at times. There have been policymakers who have questioned the evidence and have pushed back around that. And I think it probably comes back to the same thing actually that we were just talking about, Alex, about when all of us are saying, all the clinicians, all the health professional organisations are saying, this is not just what the evidence says, but also our combined clinical expertise. There's some weight in that. But take your point too, Jane, that some people will just never be convinced. There are still people who are questioning our ivermectin recommendation 2.5 years later. Yeah, so I certainly don't have a magic wand, but I think there is something in that broad consensus and strong, rigorous evidence base.
Just to jump in there, it reminds me of some of the work that Jesse Kaufman and other people who work in the consumers and communication space have done during COVID about not as much as at a structural policy level, but more at a personal level about how to have those conversations and the different ways that that people think about evidence and take on board information that they don't necessarily agree with. So there is research out there on that's been quite interesting to read during the pandemic as well. Not my area of expertise though.
I think too, there is something about understanding the drivers of what that is. Like I'm sure Jessica's work addresses that too, but in the context of ivermectin, once there were effective drugs, ivermectin was less pushed. It was in the context where there weren't any effective interventions that people were looking for anything that might possibly work. And once there were other things to be offered, it became less of an issue. But yeah, I mean, vaccination, I know that there are lots of people who are working in that space, and that's a really challenging area too.
I think it also highlights what you were saying before with having the consensus, like how it's not just research evidence that's really important too, how there's other pieces of evidence that I think put weight to driving policy and practice as well.
Absolutely. And I mentioned very briefly our consumer panel on task force. This is one of the parts of the task force that I just love the absolute most. You know, we have a group of consumers who have either had COVID themselves or who have family members that they've cared for with COVID. And we can take them our recommendations, and they are a really great sense check for us. Like, yeah, we've taken our recommendations recently to them around pediatric treatments, and they're like, these people know the healthcare system. If the kinds of people who are suitable for these treatments, they know they've got an approach. You don't have, and just the grounding in what the real lived experience is like for families who've got kids who might be immunosuppressed or have disabilities or have complex needs. That real grounding in what else is going on in their lives has been super important.
Another question popped up in the chat there from Shirley. One of the barriers for evidence translation into practice and policy was lack or limited infrastructure and leadership. Is there anything that early career researchers can do to address that?
Well, that's a good question, isn't it?
It is. And one we're probably still trying to find the answer to.
I mean, I guess I don't have a good answer to that question, Shirley. It's a really great question. I think keep on fighting the good fight is probably part of it, right? Being a consistent voice in that space. Look, I'm a bit Pollyanna actually, but I feel like there's a tipping point, which we're kind of at now. Like, I think when I started out in this world, which was a frighteningly long time ago, we were still having to make the case for evidence. Like that was a thing that we had to advocate for. And it feels like we've moved on a long way from that now. So I feel like whilst it can seem slow and there are times where it's discouraging, that lack of infrastructure and leadership, I think things are moving in the right direction. So I encourage you, but I don't have a great answer to know practical things ECRs could do. Anybody else have any ideas?
I think joining, what I found, and I don't know if it is sort of probably not a direct answer, but there are groups out there too. I think like banding together. So one example is this SERI group. So we have an EMCR group, and we're working towards evidence research and evidence, and translating that into the specific area of prevention. But I think like that, bringing us together as a collective and being able to work on things together that aren't necessarily traditionally academic, like we're doing a lot of things that are more like blogs and op-eds and things that I never really knew about before. But yeah, I think looking for groups that are the EMCR groups that are sort of banding together to do that. I think that's probably one way that that you can do that as an ECR. And yeah, like I said, SERI is a perfect example of that.
Yeah, I agree with all that, Alex, and as could be saying in the chat, shared experience and that bonding together. I think too, if you can find, I was just thinking this before, you can find a mentor or somebody who's not maybe directly in your team, who's supportive, but is working in your local context or in your particular area, and just being able to connect in with them about what's worked in their career about this space. I think it is a challenging area to work with. It's not, it's not necessarily recognized by traditional academic metrics as being a pathway to success, and there's complexities in this space, but finding someone who you admire who's done well and shouting them a coffee might be a good way in.
Definitely. Any other questions just before we wrap up?
Alex, I was actually just going to ask you in regards to your case study of the physical activity program in schools. It's quite different from Tara's example in that like there was quite a few trials and it seems like it spanned like a large amount of time. In that time, how did you stay relevant for policymakers so that by the time you get to that optimized version of the intervention, it is still notable and still impactful on policy and change?
I think the advantage of being embedded in this health service, so having policy and service practitioners on board from the start, is really important because like we're constantly being informed about what's relevant, what's needed from the service and policy perspective. So I think that co-production and that true collaboration is probably something that was really important and also drove a lot of those updates. So like when we were trying to expand out, like looking at the cost and the strategies, that was coming from like our end user collaborators. So I think that's probably one of the main things, and just having that diversity of team from the start as well. So I think like we had teachers on board, we had members of the Department of Education and the Catholic Schools Office, as well as the local health district. So I think having the different voices and the different perspectives that were going to use this or would be informed by this was really important to have at the very beginning and at all iterations. I think it probably comes back to what Tara was talking about. Those regular meetings is what has helped with driving the COVID along. I think that helped with ours too, by having those regular meetings and that true collaboration with the people that were going to use it or that we wanted to use this evidence was really, really important.
Can I just jump in there too? Because I think sometimes we forget the really personal stuff that's a part of those conversations. The conversations that I've had on those fortnightly meetings where I found, somebody's kid's been sick and they're late to the meeting because they've had to clean up after their dog, or they've had some bike accident. It's all that kind of stuff that sits around the outside that is never on the agenda, but actually means that next time I call them, I can ask them how their daughter is, or that means that, we address each other as real people.
Yeah.
I think sometimes we think of these things as edifices, like there's the research and there's the policy, but the reality is that it's all made up of people who've got complex lives and have untrainable dogs. And that connection can be really vital part of this whole undertaking.
And I think it comes back to one of the points that was brought up in our small group about building those trusting relationships as a really important part of generating like quality evidence, but also really impactful and relevant evidence, as well as having, like realizing we're humans and being able to trust each other and having real conversations about what we need to do. Excellent. Well, I think that looks like all of our questions, and when we are coming to the end of today. So I think if we've got no other questions here, we might sort of do the wrap up if everyone's okay with that. I will just share my screen for the last little bit. Can everyone see that? Excellent. Okay. So just a few summary points that I thought were just really important take-home messages that I'd just like to emphasize. So obviously creating and using research evidence to inform policy and practice is important, but it can be difficult. But I think we've learned like some of the key strategies and things that might help to do that and improve that in our practice in the future. There are also many types of research evidence that we need to draw on, and we need to determine what's most important for the particular question at hand. So considering the wealth of evidence that we have available and not just focusing on sort of one or two specific points. Synthesis should be considered where possible, and hopefully we've given you a few tips in terms of how to easily identify those of high quality and how to interpret some of those results. And I think some of the main things that we need to also understand is that policy and practice isn't just influenced by research evidence, that it's this entire world of influences that are equally as important and that we need to fit in with those. And finally, to have policy and practice impact, we should be developed on ideas that are co-produced and that are relevant to what the policy and practice needs are. And just a few resources that I thought might be helpful for people. So if you want to have take a look at these, the Evidence Commission report is just a really good overview of this, using evidence to inform policy and practice. And it just is really easy to read. So if people are interested, provides a really good framework of developing using research for policy. This a bit biased here. This is an example of the embedded evidence practice model that we use here at Hunter New England. So draws on that case study that I presented earlier, and just provides an example of that true co-production of model. There's a few databases there that I just wanted to list that provide good resources for evidence and synthesis tools. And then finally, just some knowledge translation frameworks. So we've got the SPIRIT framework that was developed by Tari and colleagues, as well as some other knowledge translation frameworks, and some organisations that might be some touching points. I think back to Shirley's idea about as these EMCRs, like how do we get involved? These might be good places to start and get in contact with. So just like to thank everyone for coming along today, for some great discussion, and particularly to our three facilitators, Miranda, Tari and Kat. Thank you so much. I really appreciate your time and your expertise.
And thanks, Alex, for pulling it all together.
Thanks. Thanks, everyone. We've got a minute to spare to jump into the wrap up for the symposium day. Thank you again.
Thanks, everyone.
Thank you.
Gonna check if Alex
I know.
needed anything, but
I know. I think she must be good.
happy and out the door.
Yeah.
And thanks, Nick, for being our tech support back there. Oh, can't hear Nick. Nick is not muted.
Yep. Can you
There
hear me
you
now?
are.
Yeah, sorry.
All right. No, you're right. I think we're all done,
Yeah,
and
all
we'll
good.
head out.
Went really smoothly.
Head out.
Thanks, guys.
Thanks for
Thank
being there
you.
in case we needed you.
It's all
All
right.
right. See you later. See you, Kat.
Bye.